Kia ora everyone, and welcome to the first webinar, PHONZ webinar for 2023. Welcome to everybody. We hold these on a regular basis and we will be doing successive ones, and I'm delighted for our two guest presenters today, Maya Patel and Rebecca Young. Maya is a health analyst at Te Whatu Ora Counties Manukau, and Rebecca is a public health registrar at Te Whatu Ora Waitemata, and they're going to be presenting on the demography of Asian population living in the northern region. So welcome Maya and Rebecca, and thank you for giving up your lunch to give us the webinar. So over to you.
Sorry, I'll just start by sharing my screen with the slides on there. It won't be a moment. Okay.
Great. Tēnā koutou katoa. My name's Rebecca Jung, and Maya and I are really pleased to be able to present to you today some of the findings of our report that was published in June of last year, looking at the Asian populations living in the rohe of the northern region. And this is a piece of work that we worked on together, where we were both at Counties Manukau, and it was kind of intended as a gift to the then Health New Zealand and Māori Health Authority to kind of share some of the insights about the Asian populations living in this region. And of course that we take this opportunity to acknowledge that Asian Health in New Zealand is a space that was created and is kind of fed by the work of many people who've been working and advocating in this space for a long time. And also want to acknowledge our co-authors who contributed to this work. The next slide, please. So firstly, a little bit about how we approached this report. So this covers kind of our understanding as well as our positionality. So although this is an Asian health report, we're very aware that Asian communities are here with Te Tiriti o Waitangi being the country's first immigration policy, and that we also can be tangata tiriti. So that was something that we had at the top of our minds, alongside the understanding that racism in Aotearoa, including against Asian peoples, is an ongoing factor that goes through our structures, such as immigration policy, our culture, and also can impact on how we collect and interpret data. And we were also very mindful of how we thought about the concept of Asian, which although it is very useful in a pragmatic sense for looking at data, it has limitations when capturing the full depth and breadth of different identities and lived experiences for those categorized within that group. And we also kind of reflected back on the different streams of knowledge that exist within Asian health in Aotearoa. So we were also informed in this work by insights and experiences from those working in the Asian health space, as well as scanning through the literature for the different types of evidence and knowledge that is available there, as well as policy recommendations and advocacy that is being performed by different groups within Asian health. And we also kind of brainstormed some key concepts for understanding Asian health in Aotearoa, New Zealand, including cultural safety, anti-racism, diverse identities, intersectionality, and the importance of community engagement and ownership when considering data that is derived from information that the community shares with us. And all of these came together and prompted us to think about how we collect and use data in a way that reflects an understanding of those concepts, improves Asian health, and also helps us improve health equity and is responsive to our tiriti responsibilities. So those were some lofty goals that went into thinking about how we approached this project.
Thank you, Rebecca. So I'll present here for the next bunch of slides. Majority of these slides will be quite data heavy, but I'll promise to do my best in explaining those. So with regards to our project aims, we wanted to collect demographic data to inform the health service planning and implementation. And because we undertook this project at the start of the health system reform, we were quite mindful about the journey of this project as the reform has happened. We wanted to look at a regional look, thinking about the reforms and our place in the system going forward. And so majority of our analysis doesn't just focus on counties Manukau, but it also looks beyond the Auckland regions and includes Northland as well. So we have the 4 DHBs, Northland, Auckland, counties Manukau and Waitemata at the time the report was made. The majority of this was also due to the population density, which I will touch upon in future slides, where populations are living. And we also wanted to provide analysis based on ethnicity categorization, geographic distribution, age and gender, and other demographic characteristics, and also looking at social determinants of health, which for us included NZ depth scores. And as Rebecca has mentioned as well, with our responsibilities for the fertility, we wanted to make a contribution towards a rich manner enhancing fertility or Waitangi-based conversation about advancing the health and well-being of diverse Asian communities of Aotearoa. So with regards to the methodology, I must also include here that the report did not attempt to provide an array of health measures for Asian communities, but instead it focused on the demography. So for the methodology of this report, I'd like to describe our use of the HISO ethnicity data protocols and the ethnic groupings in this protocol, which are used throughout the report. And for anyone who's not familiar with this, the HISO ethnicity data protocols provide guidance on the way ethnic groups are categorised in New Zealand. And they are reported as total response ethnic groupings, sole combination, or prioritised outputs. In the health and disability sector, a super aggregate level 0 grouping is sometimes used. This is where the Asian group is bundled into other. And in our report, we do describe the variability in the application of this level 0 category and the implications of this, such as in regions with big diverse Asian populations, leading to being a barrier of responsive planning and delivery of health services. We were always quite mindful about the population and people who we were leaving behind in this report, so you will see some text and thought about that in this presentation and in the report. And just thinking towards data sources, the main data sources we did use were Census, usually resident, and estimated resident populations, and HSU data. These were chosen due to their use in counties and health service planning. And for us, the HSU data also acts as a useful cross-check to subnational population estimates. For anyone who is not familiar with health service utilisation data, this is a collection of data that is derived from linkage analysis from the health system national data collections, so populations who are accessing publicly funded health services. And just a bit of a note about geographical boundaries there. So this was at the start of the reforms where we did still have DHBs, and we've got census area units as well. And tools which we used were Excel, QGIS and RStudio. So moving on to geographical distribution, the following slides are snapshots of data from the report. I would recommend to supplement this data with the additional work in the report because some of the slides are quite heavy. So here we have the Asian population of the Northern region. So for many of you, this will be quite not surprising really, but to understand the numbers of people living in the Northern region and beyond in the country, here's a graph with the percent of Asian populations across the country by DHB, reading north to south from left to right. So at the time of the report, the latest 2021 estimated resident figures, there were 848,000 Asian people living in Aotearoa. 64% of these lived in the northern region, and 98% of these lived in the Auckland counties and Waitemata region. Looking beyond into the Asian ethnic groupings for level 2 groupings, we see that the Indian and Chinese populations were the largest ethnic groups within the Asian population in the northern region, each of those representing 35% of the total Asian population. And when we compare to the other level 1 ethnic groups in the northern region, the Asian ethnic grouping is the second largest major ethnic group after other. And other includes European and Mila groups, sitting at 45%. So in our report, we have a series of graphs, and I do apologise that this is quite big. There's a bit of information in here, but there are further graphs in the report which you can have a closer look at. But this is a map showing the level 1 Asian populations across the northern region. And what we can see here is that they are very much based in Auckland. But once we disaggregate the level 1 groupings, they are spread quite differently across the rohe, and that surprised me as well once I looked at these maps in a bit more detail. But what we wanted to say here is that any aggregation of groups can mask population distribution data, and this can certainly have a disproportionate impact on smaller ethnic groups with specific health characteristics, such as refugee communities, and that really can sort of impact on how we plan targeted services. So I'd like to move on to population projections, and I must thank Lifeng here from Waitemata for this data. So we added this in because population projection data occurs annually. Our report was done last year, and this year's data, we have noted here that there are significant differences this year, especially for the Asian population due to net migration figures, both in and out of New Zealand and moving in and out of the Northland region. And perhaps here the thing that we've taken is that when we are presenting data, is being able to have access to the most recent data is so important. And whether it's data on population, births, deaths, migration data, but being able to have a look at populations and even further ethnic groups, not just the level 1 groupings, are so useful. So I'd like to move on to complexity within the Asian ethnicity grouping, and to take a moment to think about the opportunities we took to reflect on the social meaning assigned to ethnic characterisation and the incredible diversity that exists within this population. Although we've had a lot of number crunching in this report, we acknowledge that ethnicity is complex, it's changeable, and it's socially constructed. We've thought many times about how we can best use data that at times dismisses multi-ethnic participants or uses an externally imposed prioritisation scheme. We also discussed the balance between understanding that ethnicity is self-identified versus using prioritised ethnicity data in healthcare planning. So lots of thoughts there. I'll move on to languages spoken, which we obtained from the last census. And our analysis here has been done with the acknowledgement that people can speak many languages but may not identify with the common ethnic group from which the language originated from. And so the information that we did gather from the census breaks the languages by ethnic grouping. We also acknowledge that many people may understand a language but may not speak it with confidence. From a health service and planning perspective, the data we found showed that a significant number of the Asian population would have difficulties accessing English-only services or information. And although most people within the Asian grouping are multilingual, in 2021, around 85,000 would not be able to have a conversation in English. And it is incredibly important for people to have access to the services they need to achieve good health. And for many, that could include access to interpreter services, and communication that fits in with cultural needs and that is respectful. We also looked at religion, as faith and communities can be important places of engagement in relation to well-being issues and can inform what culturally safe and appropriate healthcare looks like. This table shows religion, belief, philosophy identified for the Asian population as level 3 ethnic groupings in the northern region in 2018. And so from here in 2018, about a third of the population in the northern region identified themselves as having low religion. If the prevalence is applied to the estimated resident population of 2021, this would be just under 200,000 people. And our analysis also demonstrates the one dimension of diversity of the Asian ethnic grouping and the need to think beyond stereotypes when providing culturally appropriate and safe care to these communities. In a practical sense, this analysis can inform how chaplaincy services within a hospital could be organised to meet the needs of the Asian population. It also identifies a structural bias within the data collection process, as Hinduism and Islam are aggregated into single categories, while Christianity is expressed with more nuance. And so briefly touching upon birthplace, our analysis found that a high proportion of the Asian population in the northern region were born overseas. And we acknowledge that there's also a significant number of people who are counted as Asian, who will have characteristics, identities and expectations that may be very similar or may be very different to their migrant elders. And now I'll move on to the final bundle of slides from me, which includes examples about aggregation of ethnic groupings. So for age structures between the Asian and other level 1 ethnic groupings, the Asian population is represented here with the blue line, and we can see here that they have quite a different age structure to other level 1 ethnic groupings here. As we disaggregate the Asian ethnic groupings here, we can see again that there are quite large differences between the groups. And the differences in age structures of ethnicities were a signal to consider other methods and related details that exist within the different ethnic groups. And perhaps age standardization is one method that helps compare the statistics of populations with different age structures. Although this is just one example, as we disaggregate the groups as much as we could, whether it was to level 2 or level 3 or level 4 in the report, based on our data sources and the limitations of those, we notice large differences between the groups as each time we disaggregate the groups. This is just one example, though, of the disaggregation. And this flows, the information on age that we have flows on quite nicely to life expectancy. And life expectancy is provided in the report as a summative measure of influences on mortality across the lifespan, as an introduction on the section pointing to other publications and sources of information about health and well-being for Asian communities that you'll see in the report. But here is a graph from our colleagues on their last report on life expectancy. And we can see here that the life expectancy of the Asian population across the Auckland DHBs shows that Waitemata has the overall highest, followed by Auckland and then counties. In our report, we also discussed the further analysis in age structures of subpopulations can describe some of the differences between Asian populations, but we also talk about that analysis is dependent on large denominator sizes, which can affect the smaller numbers of people in disaggregated ethnic groups, as well as low density population areas, such as smaller areas in Northland where there are populations living. A final measure that I wanted to share with you was our findings on deprivation. So socioeconomic deprivation for children is one example from the deprivation section here. We collected this data from HSU-derived populations. And this table here shows the percentage of children in Asian ethnic groupings in quintile 5, the most deprived quintile, as a percentage of the total children for that ethnic group. So, for example, for the Asian population in Northern region, 15% of all children are living in quintile 5. And for numbers, this is 15,000 children in Northern region. This data overall shows that significant proportions of the Asian population in the Northern region experience high levels of socioeconomic deprivation. Some communities, such as counties Manukau, Auckland, Indian, Southeast Asian groups, are disproportionately impacted. We would, I guess, naturally expect to see a 20% population in each of the quintiles, quintiles 1, 2, 3, 4, and 5, but we can see here that some of the numbers are below 20, some of them are above 20. And we also conducted this analysis for adults as well, and they show similar distributions in terms of percentages. And for numbers, about 72,000 Asian adults were in quintile 5. In 2021, they represent 16% of the total Asian adult population. So this final slide from me before I hand you back to Rebecca highlights a few points about implications for health. In the report, we do point to other health needs assessments, and we acknowledge that there's an incredible amount of work that has been done and is being done in this space, or is being thought of as well. I will pass you back to Rebecca, who will talk about cultural safety and the Asian community demography.
Thanks, Maya. So just wanted to acknowledge Maya for the amazing work that she has done for this report. It was a pleasure to work with her, and it's always a pleasure presenting our work together. So thinking back to those kind of key concepts that we discussed at the beginning of our presentation, we felt that our findings with this report really highlighted the importance of cultural safety, which often is thought of as quite a clinician to patient relationship concept, but we thought was also relevant when thinking about how we use and interpret the data of different communities. And as you probably already know, cultural safety is a concept that was developed by Irihapati Ramsden, and it's about respecting and recognizing difference, as well as different power relationships that exist between service providers and the people using the service. And safety is defined by the people using the service. And from just the results that we were able to get from the data we had access to, I think a key takeaway is that Asian contains a lot of diversity, and there's a lot that we can't kind of assume based on just that categorization alone. And even that diversity is lost when we start grouping Asian within the level 0 European other grouping, and that invisibilizes a significant proportion of the population. And our analysis also highlighted some limitations of the current data systems, and which in turn highlights that at a governance level, perhaps more needs to be done in terms of ensuring that people with different lived experiences need to be represented in order to ensure that the governance is appropriate for the population of the region. I think another important takeaway from our report is that the uncritical use of aggregated data may inadvertently endorse the existence of a homogeneous Asian health profile, when even the few points we presented to you today shows that people are not all the same within this grouping, and in fact suggesting that there is one stereotyped type of Asianness fuels racism in itself. So that's kind of important to remember to ensure that we're not inadvertently causing harm. Talking to Barry a little bit before we started our presentation, he said that one of the purposes of PHONZ was about taking information to intelligence, and we tried to do this by taking the results of our analyses and deriving some recommendations that we hope will be useful for those working with data from Asian communities. So firstly, we thought that given the proportion of the Asian population residing in the northern region, routine data collection and reporting for this group was required, and that although the census was useful in providing some insight, there were also some limitations, suggesting more needs to be done to strengthen how we collect and analyze data in this space. And also, I know I've been harping on, but greater recognition of diverse health profiles within the grouping was also something we thought was sorely needed. And even just that first step of going to level 2 classification so that the Chinese and Indian groupings can be analysed separately would be a great first step. And finally, we had some recommendations about how health services could become more responsive based on some of the insights provided in our report. And happily, some of our recommendations fit quite well with the Ministry for Ethnic Communities strategy that was released last year. Firstly, thinking about representation and data policy and leadership areas, and also thinking about how government services, which of course includes the healthcare system, is more equitable in providing services to ethnic communities, and also tracks data and outcomes, and also includes the community voices in doing this work. And we also wanted to highlight some recent Asian health advocacy, because of course we're just a small piece of all the work that is going on, and just wanted to acknowledge the work that is going on in these different spaces and collectives to help improve the health and well-being of Asian communities in Aotearoa. And thank you so much for taking time out of your day to listen to our presentation. Our report is available at the link on the slide. We acknowledge all the people who helped put this together, and feel free to ask questions now and get in touch with either of us after today. Thank you.